Zoe. Yes, I'm going to talk to you about some of the work I've been doing as part of the Children's Cancer Research Group here at the University of Leeds. So we're based at St James's University Hospital, so just a few miles out of town. So some good news. So we know that translational research does work. So there has been an improvement in survival for young people with cancer than ever before. So we're now seeing 80% survival in 2022. But of course, there is a lot more to do. So the focus of my work in the Children's Cancer Research Group is Ewing sarcoma, and we're about 100 years, just over 100 years on, from when James Ewing first described the first case of Ewing sarcoma. And I'm sure I'll just show you there, that's a picture of a Ewing sarcoma tissue and what it looks like under the microscope when it's been stained. And I'm sure you're all aware this is a cancer of soft tissue and bony sites, and it's the second most frequent primary bone tumour. So, as widely reported in the statistics, metastasis at diagnosis is generally linked with a poorer outcome than for patients with localised disease. However, for many patients, or some patients with localised disease, their disease may relapse, it may come back, and we're currently actually unable to identify who those patients might be. So what we really need is some new biomarkers to try and identify these patients and improve the stratification at diagnosis. So again, as you all know, treatment consists of surgery, radiotherapy, and chemotherapy, using a lot of multi-agent chemotherapies that were actually developed in the 60s and 70s to target rapidly dividing cells. So we also need improved therapeutic strategies to target this metastatic sort of drug-resistant disease that leads to this relapse. And again, as I'm sure you all know, that we see different responses to chemotherapy for these patients. So following treatment, some patients do see complete response and cure. For some patients, despite treatment with chemotherapy, we do see some cells survive that might be able to repopulate the tumour. And despite more chemotherapy, the tumour still persists, leading to partial response, progression, or even relapse. So we sort of try in our group to try and treat with, our hypothesis really is that if we treat with chemotherapy, we can kill some of the cancer cells, that does work. But if we can combine this with potentially a targeted treatment that might need to cure, we destroy all the cells. So to try and identify some new treatments, I've been using what we call patient-derived cells. So I receive tumours from a panel of the surgical centres across the UK, mainly Birmingham, Newcastle, and then any surgeries that happen in Leeds. They're actually sent to me in the post, in cell media, and then I'm able to grow these cells in the lab, and we call them patient-derived Ewing sarcoma cultures. And I'm actually able to isolate these sort of self-renewing chemo-resistant cells, so those cells that can survive that initial chemotherapy and potentially repopulate the tumour. I can isolate these from the tumour bulk in our lab in Leeds. And the samples are collected as part of a biological study known as Ewing, and that's just the information for the study. So using these patient-derived cells, we're trying to do two things, as I kind of alluded to earlier. We're using the cells to identify potentially new treatments, using drug repurposing to try and find some drugs that will kill all the cells, so some novel treatments. But we're also looking at the transcriptome. So this is what genes are turned on and off, which genes are being made into RNA, transcribed into RNA, to identify genes that are highly expressed in these really aggressive cells responsible for relapse, to try and identify some novel biomarkers. So how can we identify those patients that are likely to relapse? So using the patient-derived cells, in a study that we published last year, we identified neurexin-1, which is a protein that is when it's highly expressed in patients, particularly patients with localized disease, that is linked with the patient more likely to relapse and have a poorer outcome compared to if you have lower levels of the protein, that's linked to a better outcome. So we might imagine that potentially we could test patients with localized disease, and then maybe those with high expression could be stratified into a higher risk group for potentially a different or more intensive treatment, and then potentially those with low expression of something like neurexin-1 could be put into a low risk treatment group. And I'm also using the cells, as I mentioned, to try and identify new drugs. So these are drugs that are targeted, so targeting some of these proteins that we've identified that are really highly expressed in these cells responsible for relapse, and also drug repurposing, to looking at drugs that are widely used in either to treat other cancers or to treat other diseases. And to identify how well the drugs are working, I use something called high content imaging, and I use this machine that's known as an operator, and it's about this big. It sits on the bench and it allows me to scan plates of cells, and this is just an example of what the images look like here. So this is cells, that Ewing sarcoma cells that are just growing in culture, and then when I add a drug, I can see that the number of cells has decreased. And I can use a software to automatically count these. So this is just some Ewing sarcoma cells where I've been able to identify the nuclei, so these blue dots within the cells. I use another dye called TOTO3 to identify the cytoplasm, so this red staining, so the outside of the cell, and then the software can actually count the cells for me. So this is what I use to screen for drugs to identify new treatments. So this is kind of leading on to where we hope to be, so this more personalised medicine approach. So rather than a one treatment fits all, we might imagine that using our biomarkers, we can split patients into potentially low, medium and high risk group for a more personalised medicine approach. So stratify the patients so they receive the most effective treatment whilst minimising side effects, but based on the biology and the needs of the patient. So using our patient-derived cells, we have identified some drugs that we're currently working on at the moment, and we've also been able to identify some new biomarkers, so neurexin-1, as I mentioned earlier. So this strategy really works to identify these two important factors. So the work in our group, the Children's Cancer Research Group, is funded by a variety of funders, including the Bone Cancer Research Trust. And I'd just like to acknowledge everyone in our group, and particularly the director, Professor Sue Birchall. We collaborate with a lot of people within the University of Leeds, and then also across the UK, we collaborate with a lot of clinical colleagues. Thank you.
Does anyone have any questions for Liz?
Hiya. So,
Hello.
not that I want to try and nail you down to this, but if I'm thinking it, other people might be thinking it. So neurexin-1, we know that it can be used to predict outcome. What can we do to make sure that new patients now are being identified, if they've got that, to try and inform their treatment? What's the next steps to try and bring about that change?
So we've started the next steps. So the cohorts that we used in our paper are very big for Ewing sarcoma, but not hundreds of patients. So we're currently validating neurexin-1 as a marker in a really large cohort of patients. Sort of it's nearly 400 patients, is it, Sue? Yeah. By collaborating.
With our colleagues in France and Spain,
Yeah.
who put patients into Ewing 2012. So is there anybody here who donated tissue while they were being treated on Ewing 2012? Thank you so much. This is actively being used in research projects that will feed back into your care and management. So
Is it something that could be part of into Ewing 1?
Yes, I think.
So
yeah,
for those that don't know.
Brennan in Manchester is running. Into Ewing 1 is going to open in the UK November or December. So this marker isn't built into the trial stratification at this point, because we need to get that trial open as soon as possible. We can't delay that. And until we've validated this marker in a large group, we can't put it into the trial. However, if the marker's validated in the next 3 to 4 months, which is the timeline we're looking at, there's a possibility of making an amendment to the trial and using it. It'll be particularly important for patients with localised disease who are currently, we don't know which of those patients with localised disease are going to benefit from the current treatment. If this marker validates, it could be introduced at the beginning of diagnosis to put those patients that we predict have got high risk of having the worst outcomes into the higher treatment group. But it is all dependent on validation in sufficient numbers.
want to change management of patients without being confident that what we're seeing is really going to make a difference for the patient.
No, it's brilliant. Really good.